Hello, I'm Camilla Carr. On today's program, we're going to be talking about medical research scandals and how they can be prevented. Welcome to For Your Health. In 1997, then President Clinton apologized for the Public Health Service study of untreated syphilis in Tuskegee, Alabama. He said it was, quote, deeply, profoundly, and morally wrong. History has shown that this wasn't the first or the last such tragedy with regards to medical research scandals. Joining us today with our studio audience to talk about some of these scandals and how we can prevent them from happening is Dr. Claudia Baquet, Director of the Center for Health Policy at the University of Maryland School of Medicine and Principal Investigator at the University of Maryland Baltimore National Bioethics Research Center. Thank you for joining us.
Thank you.
For people, why don't we start right from the beginning, what it was, the Tuskegee experiment, as it's called.
Okay. In 1932, the federal government, through the U.S. Public Health Service, recruited African-American men in rural Macon County, Alabama. The town is called Tuskegee, Alabama. And it was to observe the natural history of the disease called syphilis. There were 400 men with the disease recruited and 200 men who were African-American from that rural county without the disease for comparison purposes. And the federal government was going to observe what happened with syphilis in these patients if they were untreated. Men were recruited to the study and offered health insurance, food, and burial insurance.
Burial insurance?
Burial insurance,
That
yes.
wasn't a tip-off right then?
Apparently not, because the men continued to participate. And we know that in the mid-40s, the cure for syphilis was penicillin, and this was intentionally withheld from treatment for the men, so therefore their disease continued to progress.
This was the 400?
Yeah, the 400 men.
Okay.
And what happened was there were, over the course of the time of the study, there were Centers for Disease Control blue ribbon panels that got together to review whether they should continue the study in the 60s. And there was one physician who was not a researcher on the study that said we should stop it, but the rest of the group voted to continue it. So the study continued until it was exposed in the New York Times by an investigator reporter named Heller, and then the study was immediately shut down in about 1972. So it became the longest medical observational study, fraught with lack of ethics and violation of the rights of the patients, and health consequences and even death in the patients and disease in some of their spouses.
What were some of the health consequences?
What happens with syphilis, there's a local, because it's a sexually transmitted diseases, there are local manifestations of the disease, of course, in the private parts of the genitalia. But as syphilis progresses untreated, it can cause very severe heart disease and rupture of the heart, as well as what we call dementia, where the agent that causes the disease can get up in your spinal cord and then in the brain and cause mental deficits. And I actually, as a medical student at Meharry Medical College in Nashville, went to Tuskegee twice for my medical student training, one for obstetrics and gynecology, one for internal medicine. And while doing medicine at the VA hospital, I had some of those patients in the locked psychiatric ward that had dementia from untreated syphilis that was allowed to progress until they had mental and some cardiovascular deficits from it.
I assume they were being treated then, but was it a little too late?
Yeah, I mean, once the disease has, they were treated in terms of active infection, but once the disease causes these sequelae or outcomes, once it's progressive, you can't reverse those. And so yes, there were mental deficits, as well as severe significant heart disease in those patients.
What about family members? You said some of them were infected.
Some of the spouses of the men who were infected became infected, and there's no record that they were offered treatment either, since the men who were in the study were not. And there were suggestions of birth defects in some of the babies that were born to the couples that had untreated syphilis. So it had broad consequences, not obviously immediately for the men and their families, but also for the community and the national scandal that this caused, and the outrage of allowing this type of research, federally sponsored, to progress and withholding a successful treatment from African American men.
What was the rationale in 1970 or before it was exposed for continuing with this study?
I would say that very different than what we have now. There weren't the checks and balances. There weren't the protections for people who volunteer that there are today. People had made decisions on continuation of the study without any consideration of the ethical or medical consequences for the patients. So they were left unchecked, and they just allowed it. Even the Blue Ribbon Panel in the 60s allowed the study to continue and vote against this one person that voted to stop the study at that time. It continued another about 10 years.
Are there any descendants of these men still living, or?
There are removed descendants in parts of Alabama. As you can imagine, when there's an annual celebration to commemorate the apology of President Clinton in Tuskegee, Alabama. I participated in that last spring. And there were some family members present that were remote relatives of participants. But as you can imagine, that's very stigmatizing to come out and publicly admit that you're part of the family that was exploited in this way. So there's not what I would say a systematic listing of family members that are remaining from the participants.
Could you describe the scene a little bit more of this event?
Of the
reunion?
Yeah, the reunion.
And what was the reason for it?
I mean, the commemoration of it?
Okay. Who prompted it?
Yeah, the National Bioethics Center at Tuskegee University in Tuskegee, Alabama, has all the original papers. It's fantastic to go and visit. All the original papers from the study and records from conversations with the men who participated and their families. And they have archived these for anyone in the country that wants to go and spend some time there to look through this record of the study and its impact. And so, in order to make sure that these types of scandals of the past are not forgotten, the university sets up an annual commemoration of the apology of President Clinton. That study, there's not been a study like that since, in terms of the longest medical observational study where treatment was intentionally withheld from men, and then as a result there was a widespread illness and in most of them ultimately death. And so Tuskegee University feels compelled to be sure that people don't forget these scandals, and how that this study helped influence what we now call some of the research participant protections that the federal government has come up with in law and also in regulations. And one of the main ones is it formed some of the basis for what's called informed consent. That is, the formal process that a researcher must take part in when they're trying to recruit someone to volunteer for one of their medical research studies. There has to be a written informed consent. It has to be understandable. What we tell the public in our educational program, so that people know how the research protections of the present can prevent these scandals of the past from reoccurring, is that make sure that you understand what the study's about, that you can understand every word in the consent form before you sign it, there has to be what's called IRB, or Institutional Review Board, approved consent form. And the IRB, or Institutional Review Board, is another protection. It says that anyone doing legitimate research with ethical protections for people who volunteer have to have an independent group called an IRB, or Institutional Review Board, review the studies for safety, ethics, science, impartiality, and protection of anyone that volunteers. So the study in Alabama had far-reaching consequences for guiding how we try to avoid those kind of pitfalls of the past. And because of the outrage involved with exposure of the study, informed consent, institutional review boards came into place. It had a great influence on that. So any legitimate researcher knows this history, knows informed consent, and knows IRBs. What we're saying, too, is that the general public, an informed consumer, needs to understand what some of these regulations are and how to protect themselves if they're asked to participate in a study.
I want to go back to the Tuskegee. Did you happen to read any of the conversations between the men and the doctors?
Yes, I did. And typical interaction between a physician who was following up with a patient that they'd been following with a disease. But what was missing was a discussion about there's this new treatment to cure you called penicillin that was completely withheld. It was just an average conversation between a doctor.
How are you feeling?
Yeah, how are you doing? We're going to take your blood. Here's a certificate for all your years of participating in the study. The archives have letters that the study team sent to the men that said, you need to come in to get your treatment. This is your last chance to get your treatment. It was a way to entice people to make sure they came back. But when they came back, there was no treatment that was given to them. Their blood was taken, and then measurements were made. And there's some very interesting photographs of that.
That's really incredible. We need to take a break at this moment, but don't go anywhere because we'll be right back to continue this discussion.
It's one of the many ways to fight osteoarthritis pain. For more information on managing pain, go to fightarthritispain.org.
Some parents are afraid to let their children play.
I start coughing and stuff. I have asthma.
Asthma isn't curable.
My chest be hurt.
But with the right medication, asthma symptoms are preventable.
The asthma never slows me down.
It can be controlled.
You can get asthma under control and give your child the ability to
play hard
and breathe easy. For more information, visit playhardbreatheeasy.com.
I'm Ian. I'm 6. Hey, I have diabetes. I was 100 days before I got diabetes. It's not that good. Diabetes is weird. Do you have diabetes?
Yeah. My name's Kim. I have diabetes.
In my life, there will be a cure. There will be a cure. We need a cure.
How can you help?
You know, I never knew how serious this AIDS thing was until it hit close to home. My brother used to be a straight-up player, and I used to want to be just like him. So I found out he was HIV positive. I mean, that thing changed my whole perspective on life completely. And it let me know you gotta resist in order to exist. So get tested and know your status. Spread the word, not the disease, because AIDS is no...
Welcome back to For Your Health, where our guest is Dr. Claudia Baquet, Principal Investigator at the University of Maryland, Baltimore National Bioethics Research Center. And we've been talking about medical scandals, research scandals, and we were earlier we were talking about the Tuskegee scandal, which is the longest running research project involved with this kind of outcome. However, there have been some others. Could you tell us about those?
In 1990, Arizona State University met with the Havasupai tribe. The Havasupai tribe is in the base of the Grand Canyon. And the tribe had a history of very high diabetes rates. And so they met with the tribe and asked to take tissue and blood from them to be able to study diabetes. That's what they were told verbally. And so the tribe said, well, this is good. The tribal council agreed to the study. People volunteered and gave their tissue. But what happened was, after the diabetes study, the university investigators used their tissue and their blood to study other disorders that they hadn't discussed with the tribe, such as schizophrenia. And there was also a study about intermarriage. And the way that this was exposed to the tribe is that a young Havasupai graduate student at the university was sitting in a lecture, and one of the investigators talked about the intermarriage and schizophrenia study using the tribe's specimens. And the person knew, the young lady knew that they did not have permission to do that. So it became an expose. Research was shut down at the university for a time. The tribe protested and eventually sued the university, was awarded about $700,000 and was allowed to come through a ceremonial process to recoup their specimens. And so what happens, again, when you have individuals making a verbal statement as their intent to use your tissue, but then actually doing something else and publishing lots of papers without talking to the tribe, you have a perpetuation of distrust between an academic, a researcher, and a community that's traditionally been exploited and is underserved.
How could this have happened if, following the Tuskegee study, they put in these checks and balances?
It's because the field of bioethics and research ethics is relatively new and continues to evolve as there is the development of an ethical issue. And for this type of ethical issue, it was saying verbally that the intent to use your tissue was for one study, and then after getting the tissue, using it for something else without tribal permission. What happens with, and this is very widespread, when people collect tissue from an individual, such as someone has a lump and they go to surgery and have it removed, they'll sign a consent form to have the surgery, but often there's fine print that people typically don't read that says, I have permission to use your tissue for whatever I want to use it for, whatever research. And there's this dialogue now between, if you donate your tissue to a study, who owns your tissue after you donate it? Mm-hmm. There's a lot of legal wrangling right now, that once you give it, the investigator owns it and has the right to do whatever they want with it. What's happened because of this case with the Havasupai tribe is there's a dialogue now about what is true informed consent when you're partnering with underserved and diverse communities. And so there's some arguments now that you can either have what's called a blanket informed consent or consent form when you donate tissue, meaning that if I donate my blood, then I'm telling them they can do whatever they want. Even if 20 years from now they decide they find something else they want to study, they don't have to come back to me. The tribe has said, well, we would have preferred what's called tiered consent. We give you the tissue for diabetes, but if you want to do something else, you must come back to us. So there's this argument that's going on now in the field of bioethics to decide what is the best way to do this. I would say in working with communities who traditionally have been exploited and underrepresented in research, that it's the investigator that has to go beyond the call of duty in terms of communicating what their true intent is.
While we're on the topic of tissue donation, there was another infamous study.
Yes.
That happened, I believe, in the 1930s?
Yes. And this was related to Baltimore, and Henrietta Lacks, who I'm sure many people have heard about her, and her contributions to medicine have been incredible, because she had a type of cell that no one had ever seen before. It just didn't die. And investigators were able to use tissue that they took from her when she presented at the hospital for cervical cancer and bleeding. They were able to take that tissue, reproduce it in the lab, and then for decades be able to produce advances in polio and a host of other diseases, and also get very wealthy from using her tissue. And this happened when there wasn't informed consent procedures. You could consent to have your tissue removed if you wanted to have your diagnosis for a certain cancer, which she did. But using the tissue further, there were no guidelines at that time. I find it interesting. I had the privilege of sitting on a panel with one of her sons recently for a bioethics event we had. And someone in the audience who was a scientist said, well, there wasn't informed consent, so they didn't do anything wrong. And so David Lacks said, well, that may have been the case, but I would just like to have health insurance. My family and I, we don't even have health insurance, but you all continue to benefit economically from my mother's tissue. So I found that very powerful statement. So yes, there was an informed consent there. The family, I believe, is still in litigation, trying to recoup something, because she continues to.
So they're still using
absolutely,
this tissue.
Yes. I learned about the tissue was called HeLa cells to hide her identity, HeLa because of Henrietta and La from Lack, so HeLa cells. I learned about HeLa cells when I was a medical student, and I had no idea until fairly recently, maybe about a decade ago, that it was from an African-American woman who made these great contributions to advancement of medicine, but had no economic benefit, and neither has her family.
And she never knew?
No, never knew, and the only reason it became apparent to the family, how they discovered, was that the investigator institution approached the husband and the children saying, you know, we have her tissue, we've been doing these studies, we want to have your tissue to see if your cells are unique. That's how it was discovered. So I say that although there wasn't a regulation to protect what we call the autonomy of Henrietta in terms of donating her tissue, there wasn't the regulation at the time. It's, again, a lessons learned about the tremendous contributions she's made to medicine, the unfortunate economic irony of her family, and she even being buried in an unmarked grave in Virginia.
She was buried in an unmarked grave in Virginia?
Yes, and so we use Henrietta Lacks and her history, her books, when we're fortunate enough to have her son be on the panel, to teach the general public what we call research literacy, that the public needs to understand these scandals of the past, what protections came from them, and how to put them into play for themselves and for their families.
What is the reaction of her family? I mean, I heard what her son said. They don't even have health insurance.
No, they do not.
Is there anger?
Well, I've observed anger at some of the events we've had, yes. David Lacks was very gracious at the panel that I was on with him. And I found that very fascinating, because I don't think I could have been that controlled.
I know I couldn't have.
No, I don't think I could have. So some of the family members, there's anger, and it's often expressed. He was very gracious in this public forum, and he didn't have to be. But I think it's still a part of history that we need to educate the public on, so that these kinds of lack of informed consent, but of course there wasn't informed consent at that time, don't happen in the future.
The 3 studies that we've been talking about occurred here in the United States, but there's another one, and that one occurred in Guatemala. Can you tell us about that, please?
Yes. October 1st of 2010, the HHS, Health and Human Service Secretary Sebelius, and the Secretary of State Clinton apologized publicly and exposed a Guatemala study. What happened was, for about a 4-year period in Guatemala, the Public Health Service, the U.S. Federal Agency for Public Health, had worked with individuals in Guatemala to develop and design a study to look at the natural history, again, of certain sexually transmitted illnesses. And what happened was they, in this study, intentionally infected commercial sex workers, prisoners, soldiers, as well as mentally ill individuals with sexually transmitted diseases.
What time period are we talking?
This is in the 40s for a 4-year period, while at the same time the public health study in Tuskegee was going on. In fact, both studies had a common investigator, Dr. Cutler. And the study lasted only about 4 years in Guatemala. It had recruited many more people than the study in Macon County, Alabama. It had about 1,500 individuals. And again, they were intentionally infected with one of 3 sexually transmitted diseases. What happened was when a number of people was recruited, the 1,500, which was one of their targets, and they shut down the study, there are no records that the individuals were ever treated. They started off with the commercial sex workers and then moved on to the other populations, including the soldiers. And after the study ended, there's very few records that show that those individuals who were deliberately infected were actually treated for their disease. So as you can imagine, especially involving one of the same investigators from the Macon County study and another government outside the U.S., there's a huge scandal. What happened after that announcement and public apology was a year-long study by the National Bioethics Commission that, again, stated and confirmed about a year later the lack of ethics and the lack of checks and balances in the public health service for a research project being conducted in another country, even though individuals in Guatemala sanctioned and okayed the study.
And there's no record at all of any of the people who took part?
There's very few records resulting from documentation of the treatment. Some people were, but there's no documentation that that entire 1,500 received therapy for the disease they were infected with.
So how did this particular scandal come to light?
An investigator in Pennsylvania was going through archive works from the same Dr. Cutler, and came over his records about the Guatemala study and could not believe it. And she eventually went to the archives in Pittsburgh, went through all of his records, and then exposed it. So that's how that came about.
And was this doctor ever reprimanded, or did anybody ever say, hey, you did the wrong thing?
It's interesting. I've met people in the state of Maryland who were actually trained by him, who hold him in very high regard. And to my knowledge, he wasn't then at that time reprimanded because there were no checks and balances at the time or regulations to protect. And the people that did the study and designed it, such as the one in Alabama but also in Guatemala, felt that the scientific curiosity and the need to understand these diseases outweighed the potential risk to what's called vulnerable populations. There's now regulations that protect these very type of people that participate in studies. They're called vulnerable populations, people that are mentally disabled, people that are prisoners, a captive audience, so to speak, soldiers. So there are regulations now to protect those individuals from participating in research. So around that time period for the design and implementation of these studies, without those regulations, people felt they were in their right to conduct these types of studies to advance our understanding of these diseases.
Thank you. We're going to take another break, but when we come back, we're going to go to our studio audience for them to ask questions. Stay with us.
Some parents are afraid to let their children play.
I start coughing and stuff. I have asthma.
Asthma isn't curable,
My chest be hurt.
but with the right medication, asthma symptoms are preventable.
Asthma never slows me down.
It can be controlled.
You can get asthma under control and give your child the ability to
Play hard!
and breathe easy. For more information, visit playhardbreatheeasy.com.
No!
Oops. Yeah, sure. Moms everywhere are finding ways to keep kids active and healthy. Works every time. Get ideas, get involved, get going at letsmove.gov. Weight loss, it's one of the many ways to fight osteoarthritis pain. For more information on managing pain, go to fightarthritispain.org.
All right, Baltimore, listen up. It's getting real. A lot of people are dying around us at the hands of HIV/AIDS because they're not staying protected and they're not getting tested. And take it from me, personally, it's nothing wrong with being abstinent. It's not corny. You won't get teased for it. And trust me, at the end of the day, you're doing something better for yourself than you ever will. So don't get trapped by ignorance because you want to do something to make yourself feel good. Spread the word and not the disease, because AIDS is no joke.
Welcome back to For Your Health. We've been talking with Dr. Claudia Baquet about medical research scandals, and we're now going to take some questions from our audience. Sir, your name, please.
My name is Patrick McDonald, and my question is, exactly how bad is the AIDS epidemic in the African American community as it relates to women? For many years, we thought it was a homosexual disease, and the media did a very good job of making sure that that's the hype that we believed. And so I guess I'm just wondering just how bad is the epidemic in the African American community?
The AIDS epidemic in African American women in particular is a significant and real epidemic. And you're correct, the early focus on AIDS and HIV infection was in homosexual white males. The current rate of occurrence is extremely high now for heterosexual African American women. So yes, it's a real epidemic.
There was a study that was published, correct, in the Baltimore Sun that spoke to this, but then later the two researchers, they wrote in and they said the study wasn't interpreted correctly.
Yes, there's lots of controversy from that piece, but suffice it to say that the new cases, the rate of occurrence is a significant epidemic in African American women. That is accurate.
Thank you. Sir, your name, please.
Hi, I'm Tom Summers. As a parent, we talk about informed consent, but in the reality of an emergency situation with a child at a hospital, what abilities do you have as a parent when they push that consent form in front of you to say, no, I don't want it this way. I want a broader or a more controlled use of that material that may be used in that operation.
Yes. Well, you brought up at least a couple of important points related to the research protections in different settings. So in emergency settings, such as an emergency department or emergency room case, there are different regulations that say that even in an emergency situation, for example, if a patient is, say, comatose and there's only one intervention that can help them, but they can't give consent, there are exemptions for consent for that type of situation. As a parent bringing your underage child into an emergency department, you still maintain the right to state that, one, you want to understand fully what the range of options are and what are the outcomes for those options for your child. You still have that right to do that instead of just blanketly signing a consent form. It's every parent's right, and you should exercise that right.
But if you disagree with what they put in front of you, what do you do?
Well, that's going to be, that'll be a challenge because depending on what the nature of the intervention or the nature of the emergency is, you may have the medical team kind of going against what your opposition is. I would say that for any parent with an underage child in those settings is to try to work in a collaborative way with the clinician that's trying to treat your child, and to make sure that you have adequately expressed your concerns in opposition to a particular type of therapy or intervention that they're proposing. Those are your rights.
It's interesting because I can remember going to the emergency room and I was very, very sick. I can remember I signed a couple of papers. I didn't even read them at the time because all I wanted to do was get better.
Yes, and that's the typical reaction, especially when there's an emergency. So we ask people to try to exercise their right to be sure they understand what they just signed, because there could be any number of things that you've given permission for that you didn't realize that you signed permission to act on. So we encourage people with the programs that we have out in the community to be sure that they become the most educated consumer and patient as possible and take the time to read the consent form. Sometimes, as you said, when it's a life and death situation or there's excruciating pain, it's a human case to not do that, to hurry up, get to the therapy, get rid of the pain. But in the long run, we suggest that people try to take the time, or if they're with someone, a loved one is with them, to help them go through the consent form so they really know what they've signed for, because there could be long-term ramifications.
We have another question. Ma'am, your name, please.
My name is Ava Herndon, and I'd like to know, Doctor, in the past century, vulnerable populations, blacks, Native Americans, and Hispanics, have borne the brunt of the U.S. intellectual curiosity into diseases and their cures. In the 21st century and beyond, can you tell me if any population can expect to bear that same burden?
That's a very provocative question. And I think the potential for the type of burdens placed on communities of color, underserved communities in particular, the potential for that burden is less now because of regulations. I feel that in order to assure that there's less of that burden placed on those communities, there is a desperate need for widespread, ongoing community education about the potential value of participating in research, the potential risks, the benefits, but also how to protect yourself from potential scandals and exploitation in research. Ultimately, advancements in medicine and public health come through research, and communities that have typically borne this burden have often been either in the years prior to these regulations been exploited, or now that we have regulations aren't participating at the numbers that we need to produce advancements in community health. So the solution to addressing, making sure this type of burden is not put on those communities that as it has in the past is intensive community education, ongoing education about research, what the protections are, and how to respond if someone asks you to participate in research so that your protections are implemented.
When you talk about intensive community outreach, what
Yes.
are you talking about?
We've been very fortunate to have National Institutes of Health funding to hold programs called mini medical schools. And specifically, we've had bioethics, research ethics, clinical trials, and health disparities, mini medical schools. Mini medical school is a free 4-week program that the community can attend medical school and learn about a variety of health issues, but also learn about the research protections, the histories, the tragedies, the scandals, how they can be prevented now, and what is the value of participating in research. Our 4-week program is modeled off of a 5-week program that we've had, again, free of charge, for the last 12 years that enhances community health literacy. We tailored it down to the 4-week program to enhance what we call research literacy in the general public. Then after an individual attends many medical schools, there are many opportunities for ongoing education on the World Wide Web. We even offer to the general public free of charge web-based training so they can print a certificate, take a class on the web, and print a certificate that they have received training in what's called human subjects protection training. So that's typically a training that's restricted only to researchers. But again, as our commitment to removing the mystery and stigma that's usually associated with research and the distrust that people have of the research community, we offer kind of transparency in those research tools so the public can take advantage.
Is this widely known, though?
Well, I guess it's widely known in Baltimore, on the Eastern Shore, Western Maryland, and Southern Maryland, where we hold the programs. We're trying now to package these programs to make them available nationwide. There's a great interest in regionalizing in other parts of the country this very same program. It's incredibly popular. For bioethics mini-med, over a 2-year period, 2,100 people have been educated and graduated from the mini-med program. And that, again, we hold it in Baltimore City. That's our largest group. On the Eastern Shore, Southern Maryland, in Charles County, and then in Western Maryland, in Cumberland.
If people want to know more information about this program, who can they contact?
They can call the Office of Policy and Planning at the University of Maryland Medical School at 410-706-1742.
We have another question. Sir, your name, please.
Hi, my name is John Rosenblum, and I was wondering about adaptive clinical design and what types of rights patients have during a trial if it's not going well for them. Can the doctors change the course of action? And if so, how popular or common is this adaptive design rather than a straight course of treatment?
That's a very good question. The rights, remember that an individual that participates in research is a volunteer. Their rights are, once they're participating in the study, at any time, if they're uncomfortable, they may leave a study with no penalty. And we find that most of the public is not aware that once you get in, that you can leave if you don't like it or you're not enjoying it. There are safeguards in every clinical trial or medical research study for monitoring safety and reaction. So, for example, if you're testing a new way to treat an illness, there are very rigorous IRB reviewed and approved at multiple levels recommendations for monitoring the safety of a patient. The adaptive clinical trial design is gaining in popularity. It's not as common as many investigators who are very flexible with trying to respond to patients that participate in the studies' reaction to certain therapy, but it's growing in importance and in use.
Thank you. And I'm sure we could discuss this for hours, but unfortunately, we don't have that much time. Let's take a break, and when we come back, we'll get some final comments from Dr. Baquet. Stay with us.
This is Mike. Mike is going to breakfast before he starts his day. What he doesn't realize is that Jim, his waiter, helped save his life. You see, Mike is being treated for heart disease. 10 years ago, Jim volunteered to participate in a clinical study researching a new treatment for heart disease. It was successful, and the new treatment was made available to everyone, including Mike. Like millions of other medical heroes, Jim's participation in clinical research was a gift to Mike and all people who might benefit from this new medication around the world. Just like Jim, medical heroes can be found in everyday places. To learn more about clinical research, visit CISCRIP, a nonprofit organization at medhero.org, or call 1-877-MED-HERO.
In a moment, cancer changed our lives forever.
We were told nothing could be done to enjoy these final moments together.
But in that moment, when all seemed lost,
St. Jude Children's Research Hospital gave us hope.
Because at this moment, St. Jude Children's Research Hospital is saving lives with pioneering research and care. We're changing the way the world treats childhood cancer by sharing our discoveries with doctors and scientists everywhere.
And we'll never have to pay St. Jude for anything, ever.
At this moment, she wants to be in her own bed.
I want to be back at school with my friends.
I want to be outside playing.
Please take a moment and join St. Jude in finding cures and saving children. Visit stjude.org.
Welcome back to our program where we've been discussing with Dr. Baquet about medical research scandals. Dr. Baquet, do you have any final comments?
It's very important to know history, and that's why in our community programs we teach the public about these histories, tragedies, and scandals and research. Once you know the history, then there's a greater chance for not repeating history. And it's important that the public become the most educated consumer possible, that they continue with what we call lifelong learning. Once they've learned something about clinical trials, once they've learned about medical research and its importance to advancing community health, to continue to look for avenues to increase their knowledge, but also to increase their participation in the research process when they're approached and asked to participate in a potential study.
But doesn't the history prevent many people from taking part in certain research studies?
Yeah. It has in the past. It's created distrust, it's created fear, but what I found is once you work with the community and increase research literacy and explain the potential value of research, explain what happened in the past and what regulations are in place now to prevent that from happening, there's a greater receptivity to consider participating in medical research studies. We've observed that. It's an unexpected benefit from our mini medical school program that the graduates become so empowered by the knowledge that they're often asking, well, I have a family member with arthritis, do you all have a clinical trial that I could refer my loved one to? Or I have uncontrolled hypertension, is there a blood pressure study that you can suggest to us? There's any number of resources first of all, in our Office of Policy and Planning at the medical school, in our mini-med program, but really high-quality, correct information available on the web, on the internet, through the National Institutes of Health, through the American Cancer Society, through a host of other legitimate organizations with correct information that can continually foster research and health literacy in the public. So we have seen the distrust and the fear reduce as a result of some of these programs. We didn't anticipate it would be that way so quickly.
What about cultural taboos, however?
In terms of research participation?
Yes.
Well, yes. I mean, we talked a little bit about the Havasupai tribe and the hesitance of certain communities of donating tissue, for example, feeling that a part of their spirit is in the tissue and that would diminish them spiritually as well as physically. So the cultural aspects of medical research participation and explaining the purpose of studies that communities that are underserved traditionally or have cultural barriers cannot be overemphasized. And so we talk about educating the public, but we're also training the new researchers to be able to communicate correctly with the public in literacy appropriate words. These are very complex studies often, very complex designs, but being able to explain them in a way that the lay public can understand them and then make an informed decision about whether they want to participate or not. So it's just as important to train the new and growing research community, the new investigators and scientists, in how to appropriately address cultural concerns and fear and distrust of the research community by the general public.
I'm curious, do you ever have one of the participants talk at your community meetings or during your events?
Often we will, depending on the topic. We've held many lectures on medical research, its benefits and potential risk for community participation. And we will have individuals on the panels that actually participated in clinical trials or other forms of medical research study. And they'll talk about their experiences and whether it was of value to them. We've also had family members of individuals who participated in clinical trials that perhaps weren't alive anymore, but they were very happy in saying that, you know, you assisted my father in getting into a clinical trial, and he actually lived 6 more years of good life to be with us. So we've had people thank us for that also. So they're either people who've been in the studies or their loved ones.
And that will have to be our final word, but I'd like to thank you, Dr. Baquet, and I would like to thank our studio audience and, of course, all of you for watching. I'm Camilla Carr, and we look forward to seeing you again on the next For Your Health.
We want a country where all people are reaching their highest attainable standard of health, but tragically too few people are reaching that noble goal. And oftentimes people of racial and ethnic minority backgrounds are not reaching that goal for reasons that we can rectify.
There was a time when no one talked about cancer on the reservations or throughout the American Indian Alaska Native population. But gradually there were people who started to worry that we were seeing more patients, very desperate patients with very bad prognoses, and didn't quite understand what was happening in the community.
Los tratamientos en cáncer y los problemas que los pacientes, especialmente latinos y hispanos, que ellos tienen cuando los están diagnosticando con cáncer, todas las cosas familiares, el seguro, acceso a los hospitales, eso es muy importante para mí.
As a resident, I had a gentleman to come see me. He was 59 years old. He had private insurance, and he came to see me in our ward service clinic. That meant that he waited for about 3 hours to see a resident because someone in his family had told him that they saw me give a talk in the church about prostate cancer. Now, this gentleman had been diagnosed 2 years before with a treatable cancer, but when I saw him, it had already spread to his bones. So the question for me was, why didn't this gentleman get treated? He was educated, he had insurance, so he had quote-unquote access to care. However, he did not receive appropriate care.
Well, there's a wonderful saying that the health of the individual is almost inseparable from the health of the greater community, and the health of every community determines the overall health status of the nation. So the community is the focus here. It's very important. We also know that health is more than what happens in a doctor's office. It also starts where people live, labor, learn, play, and pray. So this is a very aggressive and comprehensive plan. In fact, it represents the greatest federal commitment to eliminating health disparities ever. It also has commitments to strengthening and diversifying the workforce and holding the Department of Health and Human Services accountable for reaching these goals. There are 5 key parts to this strategy. First, to transform healthcare, particularly using the lever of the Affordable Care Act. We know that minorities make up about 1/3 of the nation's population, but about half of those uninsured. So we need to close and, in fact, eliminate that disparity and really improve access and coverage. Second, we want to strengthen and diversify workforce so people can get the culturally competent care they need and deserve. Third, we want to improve population health in a whole range of areas, from cancer to heart disease to HIV and other key areas. Fourth, and critically, we need to improve data collection because the data on disparities has been suboptimal so far. In fact, there are provisions in the Affordable Care Act to improve data collection at a granular level so we can create better strategies for eliminating disparities. And then fifth, the Affordable Care Act creates multiple new offices of minority health and, in fact, elevates the National Center for Minority Health and Health Disparities at NIH to a full-fledged institute. So these are all major commitments, and we're very, very excited about them. There's a very important saying that if you fail to plan, you plan to fail. With this new plan, we have now a commitment, a roadmap, and a compass for the future, and we're very proud of that.